Complex Nursing Case Study Presentation Group 2A-1 Adenocarcinoma Lung Cancer of Mrs. L.
This is the content of the case study.
Abstract. This case study is about a patient with stage 1 adenocarcinoma lung cancer and multiple history of medical disease. A 65 years old woman patient with a medical history of hypertension, diabetes mellitus, ischemic heart disease, triple vessel disease and chronic kidney failure have been chosen as case study with her consent. The patient have present her current problem of having prolonged cough for about 6 months. The patient condition during hospitalization is oriented, but having body weakness. On the chest X-ray, it show the left lung have thick wall, with multiple lesion on the lower lobe. Further radiology investigation have been done to confirm the disease. Cancer is caused by the uncontrolled cell division due to the mutation of the gene. Some management have been done to relieve the sign and symptom of the disease, which include oxygenation, restrict fluid, balanced diet and pharmacotherapeutic. Besides, prioritized nursing care plan have been formulated to relieve the symptom of disease. For conclusion, this case study was conducted to understand the disease process and management to relieve sign and symptom caused by it.
Introduction. Normal cells grow when our body needs them, and die when our body does not need them any longer. Cancer cells in the body start to change and grow out of control. Treatment, surgery, chemotherapy, and radiation therapy. We want to challenge ourselves to go into details about the cancer and the treatment used to treat cancer. The case also was new for us and more challenging because we have to see patients' treatment such as radiotherapy and have to give support to the patient regarding the disease.
Biographical data. Name, Mrs. L. Age, 62 years old. Gender, female. Date of admission 18th of October, 2017. Medical diagnosis: left lungs, adenocarcinoma stage 1B. Chief complaint: on March 2017, Mrs. L come to emergency department and complained of having chest pain for the past 3 weeks, that associated with shortness of breath and prolonged dry cough. The cough did not relieve, even after taking medication. Patient also verbalized, "I had loss of appetite because of the pain." Presenting symptom: site, pain at left side of the chest. Onset: the pain had lasted 3 weeks before seeking healthcare, which is around February 2017. Characteristics: she claimed that she was having a sharp pain at the left side of the chest. The pain does not relieve and worsening even after taking medication. Radiation: none. Associated signs and symptoms: she complained of shortness of breath, prolonged dry cough, loss of appetite. Time course: on-off chest pain. Exacerbating, pain worsening when doing activity such as walking and lying supine. She verbalized pain score of 7. Past health history: have hypertension, diabetes mellitus, chronic kidney disease, ischemic heart disease. Last admission, March 2017. Complained of having chest pain 6th of May, 2017. Treated for STEMI 8th of September, 2017. Complained of shortness of breath and dry cough. Have medication as in table. There is no family history of lung cancer. Mrs. L married with her husband and live with his family and also have 3 children. Non-smoker and only drink alcohol during festival.
Assessment. I. Body system. 4. Respiratory system. Lungs are clear. Symmetrical movement. During breathing. No barrel chest. And flail chest noted. Respiratory rate was 22 per minute and Oxygen saturation was 96%. For all lobes, there was no wheezing or crackles sound can be heard. For cardiovascular system, no palpitation was noted. Blood pressure was 160 for 68 millimeters of mercury. Pulse rate 64 beats per minute. Pulses was regular. For gastrointestinal system, her abdomen was flat, with no sign of ascites. Skin was also intact, no striae, no obvious visible veins, and peristalsis movement was noted. Her bowel sounds was present. For neuromuscular system, eyes was clear, with no watering and no reddened. Pupils equal for both left and right eyes, and both eyes can react to light well. For musculoskeletal system, she has unsteady balance and gait due to weakness on both legs.
Assessment. Focus on complaining area. Complained chest pain. Verbalized pain score of 7/10. Claimed the pain not radiated to other region. No tenderness on chest wall. Heart sound normal. Pulses was regular, by primary or secondary survey principles. Ambulated slowly and required assisted in doing ADL fairly weak, alert, cooperative. Oriented no denture. Did not have difficulty in falling asleep. Impaired of hearing on both ears. Once or twice bowel open urinate 5 times per day. Vital sign, BP, 153, 79 millimeters of mercury respiration rate, 28 per minute temperature, 37 degrees Celsius SpO2, 98%, after given nebulizer AVN times 2, GCS, 15/15. This is the result of blood, urea, serum and electrolyte or creatinine on 7th of November, 2017. This is the result of FBC taken on 5th of November, 2017. Radiology investigation, on chest X-ray, there thick-walled cavitary lesion at left lower lobe of 3 times 3.5 km. Sec thorax show left lower lobe lesion 4.9 times 2.6 times 4.2 centimeters. The other investigation result as in table. On PET scan, FDG avid malignancy in the left lung. No nodal or distant metastasis. FDG hypermetabolic at the cervical node is likely due to infection/inflammation. Bone scan, no bone metastasis.
Disease process. Normal anatomy and physiology of lung.
Our lungs are 2 sponge-like organs in our chest, where our right lung has 3 sections, which called lobes, and left lung has 2 lobes. When we breathe in, air enters through our mouth or nose, and goes into our lungs through the trachea, which called windpipe. At the end of the bronchioles, there are tiny air sacs known as alveoli. The alveoli absorb oxygen from the inhaled air into our blood, and remove carbon dioxide from the blood. Carbon dioxide is expelled from the body when we exhale. Taking in oxygen and getting rid of carbon dioxide are our lungs' main functions. Disease process. Abnormal physiology. Exposure to particular agents such as environmental or occupation are thought to contribute to risk of developing lung cancer. Lung cancer occurs in people who never smoked, and in those who never had prolonged exposure to second-hand smoke. Smoking causes lung cancer by damaging the cells that line the lungs. When we inhale cigarette smoke, which is full of cancer-causing substances, such as carcinogens, changes in the lung tissue begin almost immediately. At first our body may be able to repair this damage, but with each repeated exposure, normal cells that line our lungs are increasingly and continuously damaged. The damage causes the cells to act abnormally, and cancer may develop. This is the example image of the lungs cancer of stage 1A and 1B.
Medical management. Nasal prong 2 liter per minute is delivered on 20th October 2017 due to low oxygen saturation and patient complaint of shortness of breath. Blood transfusion, which is 1 pint of Paxil, is done on 19th October 2017 due to low level of hematocrit and mean corpuscular volume. Electrocardiography ECG test is done on 20th October 2017 due to patient complaint of chest pain. Dextrose hippocount test is done, TDS daily, to monitor patient's uncontrolled diabetes mellitus. Nutrition management, restrict fluid 1 liter per day, is ordered to patient to avoid fluid overload as she have chronic kidney disease. A low sodium diet is ordered because the patient having uncontrolled hypertension. Strict intake and output charting of patient. Novosaurus renal supplement is given to patient to provide high energy density, high protein, and that less stress on the kidney to process. Blood laboratory investigation. This is the results of FBC in blood, urea, serum and electrolytes for certain day. This is the results for LFT. This is the results for PT, PTT, FLP, FBS of patient. Radiology management. Chest X-ray, F18 FDG positron emission tomography PET CT, scan, CCT thorax scan, radiotherapy treatment, bone scan, have done to the patient. Pharmacotherapeutic management. The medication prescribed for patient are tablet atorvastatin 40 mg OD, tablet felodipine 10 mg BD, tablet prazosin 3 mg TDS for hypertension. Next, tablet aspirin 75 mg AD, mist magnesium trisilicate 15 ml TDS, tablet pantoprazole 45 mg OD, tablet Bernadryl 25 mg BD, IV Maxilin 10 mg TDS, beside the subcutaneous morphine 2 mg per 6 hours, tablet paracetamol 1 mg PRN for pain reliever. This is few nursing management that have been done to patient during hospitalization. Nursing care plan have been formulated to the patient.
Nursing care plan. This is the prioritized nursing care plan. We only discuss the first 4 of the nursing diagnosis. Nursing diagnosis number 1, altered imbalance nutrition, less than body requirement related to decreased oral intake as evidenced by patient's husband verbalized that she has loss of appetite and lost weight since 1 year ago, from 60 kilograms to 51 kilograms. Goal. Patient's appetite will increase, and able to take adequate amount of food, throughout hospitalization. Nursing intervention. Monitor patient's body weight daily, to determine if patient's weight meets the normal body mass index, and the effectiveness of interventions used to meet nutritional requirements. Monitor results of laboratory. Serum albumin, serum transferrin, total protein, urinary protein, glucose, 24-hour urinary creatinine, nitrogen, and electrolytes. To identify if there is any abnormality that contribute to malnutrition. Encourage patient to maintain proper positioning, such as sit upright while eating, to prevent epigastric discomfort, and promote good digestion of food intake. Encourage patient to eat small portion of food, but frequent such as 6 times per day, and decrease fluid intake, to facilitate gastric emptying, and stimulate appetite. Advise patient's relatives to bring food from home, to stimulate patient's appetite. Refer patient to a dietitian for complete nutrition assessment, and methods for nutritional support, to promote sufficient nutritional intake. Evaluation. Patient's appetite increase, and able to take adequate amount of food, throughout hospitalization. Assess patient's pain score, and determine the characteristics of pain, to implement further treatment, to reduce the pain. Second, encourage patient to rest in bed, whenever feels pain, because moving around, can trigger and stimulate, the pain. Provide non-pharmacological comfort measures, such as position patient, according to her preferable position, massaging, provide quiet, and calm environment, to promote relaxation, and manage the pain. Encourage patient to manage pain, by doing some activities, to distract the pain, such as listen to music, sleeping, playing games, and communicate with family, so that patient can relax, and forget about the pain. Administer analgesic, such as morphine as prescribed by doctor, to help in reducing the degree of pain. Evaluation, patient verbalized that the pain was reduced with pain score of 2/10 within 24 hours. Nursing intervention. Assess and observe patient mobility and physical activity level to determine patient's condition for further intervention. Observe and assess emotional responses to performed activities. Encourage patient to do physical activities regularly in order to strengthen cardiovascular system and prevent muscle atrophy. Allow and ensure patient have a proper rest periods in between physical activity, to ensure optimal performance during sessions. Advise and encourage patient to eat healthy balanced diet, especially food with high calcium diet. Collaborate with physical therapy, to help regarding exercises that can help the patient. Evaluation, patient able to perform physical and non-physical activity throughout hospitalization. Nursing diagnosis for risk for fall related to muscle weakness secondary to older age. Goal, patient will not have any incidents of fall throughout hospitalization. Nursing intervention. Assess patient for fall risk by using Morse fall risk assessment to prevent fall based on the chart provided. Move patient near to the nurse's counter to ensure safety of the patient, as nurses can observe and alert them. Provide fall alert signs at patient's bed and case note to alert healthcare providers that patient has risk for fall. Keep the bed at the lowest position to lower the risk of falls and serious injury. Place patient's belonging within easy reach such as water, handphone and food. Encourage patient to wear non-slippery shoes or slippers such as by using non-skid soles when walking to prevent fall. Collaborate with physiotherapy for musculoskeletal assessment and plan for strengthening exercise and gait training to increase mobility. Evaluation, patient did not have any incidents of fall throughout hospitalization. Discussion, according to National Cancer Institute, 2015, adenocarcinoma is cancer begin in the cells of the glands. Lung cells contain more glandular cell. Wistuba and Brambilla, 2014, have stated that there are 40% of all lung cancer was account from adenocarcinoma, which found more often in women, and the destruct cell are tend to grow more slowly than usual. Adenocarcinoma tend to develop in smaller airways such as bronchial and usually at the outer layer of the lungs edges because it is non-small cell lung cancer. Adenocarcinoma is a type of lung cancer in people who had never smoked. This concept have concurrent with patient and her family history that there are never smoked within their family.
Based on Mori 2017, Patient with non-small cell lung cancer mutually exclusive having mutation in epidermal growth factor receptor EGFR and CRAS and anaplastic lymphoma kinase, according to International Association for the Study of Lung Cancer and European Respiratory Society. 50.5% of the surgically resected of lung adenocarcinoma were identified EGFR mutation, and Mrs. L EGFR mutation analysis have shown sensitizing mutation detected. This strongly suggested that the cancer is not triggering from environment factor. Based on Shim-Ampersand-Lee 2011, mutation were associated with micropapillary predominant subtype, and the presence of lipidic pattern is known as bronchial-alveolar carcinoma.
Based on American Cancer Society 2016, adenocarcinoma has prognosis of 45% to 49% of 5 years survival rate for the early stages. Thus, the disease may be curable in the early stages based on the patient condition, but it's just an estimated by the scientist, as Mrs. L have many underlying past medical history such as chronic kidney disease, ischemic heart disease and diabetes mellitus. The treatment her disease was limited. However, the sign and symptom of this adenocarcinoma lung cancer such as shortness of breath and chest pain should be relieved or treated for the patient's comfort. From this, the nursing care plan has been formulated to provide the holistic care for the patient.
Created using Powtoon.